Four, three, one. We are live now.
Yes. Good evening and warm welcome to the 22nd session of Active Learning Session for Pediatric Orthopedic. I am Dr. Dhiren Gajwala, a pediatric orthopedic surgeon practicing in Ahmedabad. The aim of this session is to connect our trainees and the postgraduate to the world experts of pediatric orthopedic. The speaker for today's session is Professor Stuart Weinstein. He's a professor at the Department of Orthopedic Surgery at University of Iowa. He has published more than 260 scientific articles in peer-reviewed journals. And these journals are world popular journals like Journal of Pediatric Orthopedics, New England Journal of Medicine, Journal of American Medical Association, Lancet, and Nature. In addition to that, he has edited 5 major textbooks in the subject. The common one or the popular one are the Pediatric Spine, Principles and Practice, the famous Lowell and Winter Pediatric Orthopedics, and Turex Orthopedics. The most interesting thing which I always appreciate, and I always ask him questions about that along with great academic work, Professor Weinstein is bestowed upon many leadership positions. He is a past president of American Academy of Orthopedic Surgeons, the American Orthopedic Association, the American Board of Orthopedic Surgery, the Pediatric Orthopedic Society of North America, and many more. Today he is going to speak on a very useful topic, useful in a sense that everyone is interested in this topic, starting from postgraduate to pediatric orthopedic fellows. The young pediatric orthopedic surgeon and even experienced pediatric orthopedic surgeon are interested in learning the tips about the surgical tips and the techniques about closed reduction, open reduction, and various osteotomies. So after this introduction, he will have a lecture for 40-50 minutes. And after that, we will have questions. If you have any question, please write your questions in the chat box. And after the lecture, Professor Hitesh Shah will moderate the question and answer session. Before I hand over to Professor Weinstein, let me tell you about the next lecture. On the 2nd May, we have a lecture on relapsed club feet. And again, we have world authority on the topic, that is George Mercado from University of Iowa. He will be speaking on the relapsed club feet. So with that, I request Professor Weinstein to share his experience. And once again, I thank him for accepting our invitation and sharing his vast experience with us. Over to you. Thank you.
Can you see everything okay?
Yes, please. Yeah.
Okay, very good. Well, welcome everyone. It's nice to be with you. And today I'm going to talk about closed reduction. When do you do an open reduction? Obviously, these are my personal preferences based on many cases. And then when do you do, or when do I do secondary procedures, femoral or acetabular? And obviously, many of you have much more experience on the very late diagnosed DDH cases, 5, 6, maybe even 10 or 15 years of age. So my comments are mostly on very young children where I would have the most experience in my population, base. I have no industry conflicts at all. And so we're talking about children who would most often need closed or open treatment. And these are children after 6 months of age. I think most people would agree that under 6 months of age, you would have varying degrees of success with a device like the Pelvic harness or whatever your young age device would be. But after 6 months of age, the Pelvic harness failure rates are usually greater than 50%. So therefore, you're talking about probably taking a child to the operating room to consider closed or open treatment. And your goals when you go to the operating room for a closed reduction or an open reduction are to get the hip in the socket, the femoral head and the acetabulum. Your goal is then to maintain that relationship to provide for the optimum environment for acetabular and femoral head growth and development. We talked about this the last time I spoke with you about hip. And obviously, once you're out of the Pelvic harness age range and you're doing closed or open treatment, one of your biggest worries is a growth disturbance of the upper end of the femur, which is often called aseptic necrosis, which I'll ask you to start to learn to change that term to proximal femoral growth disturbance. So when you go to the operating room for a closed or open treatment, obviously the one thing you fear is getting a growth disturbance, because a growth disturbance, as we'll talk about in just a moment, will probably lead to early arthritis, as will persistent acetabular dysplasia. We talked about that last time, that persistent acetabular dysplasia in DDH always leads to osteoarthritis. So in this talk, I'll talk to you about when do I do my secondary procedures and what guidelines do I follow. So let's talk about proximal femoral growth disturbance, because I think when you're doing closed or open treatment, this is your biggest worry. And I'm going to ask you to start talking about this as proximal femoral growth disturbance, not aseptic necrosis. There has never been a human specimen described looking at the femoral head in one of these situations that shows that this is loss of blood supply. This is clearly a growth disturbance. And we know that if you get a growth disturbance, as we talked about on our last hip lecture, and you look to the slide on your right, even if the femoral head grows in a distorted fashion, the acetabulum will accommodate to that distorted femoral head over time. But nonetheless, if you get a growth disturbance, even if the acetabulum accommodates, you're talking about a child who will need a hip replacement at a much earlier age because of that growth disturbance. So what are the factors in getting a growth disturbance when you go to the operating room and think about closed or open treatment? Well, when I was a young man, traction was used, and pre-reduction traction was always used. And this is a paper I wrote back in 1997 when I looked at the evidence to say whether traction prevented growth disturbance and also if it made the reduction easier. And I would say at that time and today, but there is no evidence that traction will prevent a growth disturbance. Now, traction has been largely abandoned around the world, except in two countries, Japan and France. And if you read articles from those countries, you can find very acceptable closed treatment after long-term, and I mean many months of traction. But I would say in the developed world, traction has been gradually abandoned. What other things cause a growth disturbance? Well, it's been shown scientifically that if the only position that looks good to you in the operating room, that the femoral head and acetabulum relationship is good, is wide forced abduction, like the patient on the upper slide, or wide abduction and internal rotation, you will cause a growth disturbance. These have been shown scientifically in microsphere studies and hydrogen washout studies that you will severely impact the blood flow to the upper end of the femur. So these would be unacceptable positions. One thing that's not talked about, but which I place great stock in, is excessive pressure on the femoral head. So if you're doing a closed reduction, and let's say the picture on your left is your arthrogram, I would ask you, would you accept this or not? Well, I have many colleagues here in the US who would say that's fine, we'll just watch and wait. I would argue the opposite, that if you accept a non-anatomic reduction like the arthrogram on the left, that you're using the femoral head to overcome the obstacles of a reduction, and you're going to compress the intercartilaginous vessels, which you can see in the histologic slide on your right. These femoral heads are very soft and very vulnerable to pressure. This was shown by Salter in 1960 when he showed the effects of compression of cartilage, and also Professor Trueda, who was from Barcelona and then moved to Oxford, showed the same thing, the effect of pressure on epiphyseal cartilage. Therefore, for me, this type of arthrogram on attempted closed reduction is totally unacceptable, and I would never accept such a reduction. So what is an acceptable reduction to me? Well, the only acceptable reduction closed for me is anatomic. I want to see a perfect arthrogram like you can see on the child on your left, the radiographic appearance of the arthrogram. This to me is the only acceptable closed reduction. Now, I know if you heard from other lectures, they may differ from this, but I've given you the reason that this is the only way that is acceptable for me. And I would say that if you're talking about young children under a year of age, most children can have an acceptable closed reduction. And rarely, but not exclusively, do you need to do open treatment under 1 year of age. So when I go to the operating room, and I only do my closed reductions in the operating room, it's under general anesthesia, and most people would accompany the closed reduction with a percutaneous or open adductor tenotomy. I used to do them percutaneously in my younger days, but I found anecdotally that with one percutaneous adductor tenotomy, I decided that the reduction was not acceptable, and I opened the hip through an anteromedial approach, and I saw that I had actually cut the anterior branch of the obturator nerve with my percutaneous cut. Now, probably that's not a big deal or a terrible thing to happen, but it made me think that when you put a knife in the groin, you have no idea what you're cutting, and I prefer to do it open. So for me, when I do a closed reduction, I always accompany it by an open adductor tenotomy. And also, as in my last lecture, when I talked to you about the extra-articular obstacles to reduction, in late diagnosed cases, the iliopsoas is always tight. So through that adductor approach, I also release the iliopsoas from the lesser trochanter. Again, these are just my opinions, and I no doubt other people would disagree with some of them, but most people would do an adductor tenotomy either percutaneously or open. And then you need to document that the hip is actually reduced. I would argue that the best way to document it is by an arthrogram or a CT or MRI post-casting. I do it by arthrography in the operating room, and then I also document it post-operatively in the cast to make sure I haven't lost reduction. So I do that in the post-operative recovery room, preferably with an MRI, but if you don't have an MRI, a single cut CT scan through the triradiate cartilage. If you're lucky enough to have an O-arm, I have some colleagues who do intraoperative CT, but for me, in my 47 years of practice, I have never lost a closed reduction because I'm very meticulous about casting, which I'll show you in just a moment. But regardless, you shouldn't leave the operating room without documenting that the hip is reduced. I think the casting, at least in the US, I think is a lost art, since so much fracture work is done open. Many residents don't really have, in my opinion, excellent casting skills compared to older surgeons who had to cast fractures and do a lot of cast work. But what I think is very important is you can see me molding under the trochanters in my hip spica, and this deep molding helps prevent the hip from redislocating. And then I want to document it by an MRI, ideally, with no radiation, but sometimes MRI is not readily available, but I do document then with a CT scan through the triradiate cartilage. So I never leave the operating room without an acceptable closed reduction. If it's not acceptable, then I'm going to open it right then and there. So my program for doing closed reduction is in the operating room, always accompanied by an adductor tenotomy. And again, I also do a psoas tenotomy at the lesser trochanter, and I do these open. I only accept a perfect anatomic reduction. And then I cast the patient, as you can see in the upper left, in the so-called human position. That's a child who had bilateral treatment. And if I only find a perfect anatomic arthrogram with the hip in wide forced abduction or wide abduction internal rotation, like the lower two pictures on the right, or it's not a perfect arthrogram, I'm going to open the hip then and there. I don't reschedule the patient for another day in the operating room. I don't think it's fair to have two anesthetics. And so I'm always getting the hip in the day I go to the operating room. And then if I unfortunately have any residual growth disturbance later on and residual dysplasia, I'm always aggressive, as we talked about last time, that residual dysplasia, even in the face of a growth disturbance, is unacceptable. And you want to do everything possible to correct that. And we'll talk about that more in just a few minutes. So casting, this is a bilateral case. I use the so-called human position, hyperflexion and abduction. And I usually try and keep the children in a sitting position. When the parents pick them up, I recommend they pick them up under the cast as opposed to under the arm, so the heavy cast isn't shucking up and down. I always try to have them support the cast. For me, I always, we have things, and you may have them as well, called beanbag chairs, very cheap chair. And I usually have the children sit up all day, and I have the parents leave the diaper off, and I cover the chair with adult diapers so the children can have a bowel movement or urinate away from the cast, so they're not sitting in a dirty cast. And I try and have the children more in a reclining position, even in their crib with pillows, so that they're kind of sitting up. And I use 6 weeks below the knee to the ankle for the involved case. So this is a bilateral case. And then at 6 weeks postoperatively, I cut the cast and leave the knees and the feet free. I do not go back to the operating room to change the casts. I know many people schedule cast changes. I have a good patient population. The parents keep the children clean. So I have never, well, not never, but rarely had to go back to the operating room to change a cast. And so I leave it on for the whole 3 months. That may not work in India with the hot climate, but this is what I do. And then I go, once the 3 months in the cast is up, I go into a full-time abduction brace. The picture, the color picture, is our homemade abduction brace, but there's commercially available ones. And I use this for 2 months full-time, except for bathing. And then I monitor acetabular development. Now, the casting time and the bracing time is something I use because of tradition. My mentor, Dr. Ponsetti, did this his whole life. I've been doing it for 47 years. It's worked. Is there something magical or scientific? Can I support it by evidence? And the answer is no. So we use 6 weeks in the cast to the ankle on the involved side, cut it above the knee, and the child stays in the cast another 6 weeks. So that's 3 months in a cast, and then 2 months in a full-time brace, except for bathing. And then we let them wear the brace at nighttime as long as the child will tolerate it. Once again, no science, only tradition. So when do I do an open reduction? So as I already told you, if my closed reduction only looks good in arthrogram in one of the two positions down at the bottom, or if I don't have a perfect anatomic reduction, I'm going to do an open reduction in the operating room. Now, the anterior Smith-Peterson approach is the most common approach around the world. It's one most orthopedic surgeons are familiar with, and that is perfectly fine. Whenever you're doing an open reduction, you need to do whatever approach works for you and that you're most comfortable with. As you'll see in a moment, in the 1970s, I certainly was doing anterior Smith-Peterson, but I felt that I was always working far away from myself, away from the obstacles to reduction, which were anteromedially. So I developed this other approach, which I started using and published back in the 1970s, and I'll talk about that as well. So this is the standard anterior Smith-Peterson approach, mostly done through a so-called bikini incision. You can shift the skin and subcutaneous tissues up to the crest so that you have a scar that is in a very cosmetic location. Certainly in the Western world, where children are wearing very skimpy bathing suits, it's quite a cosmetic incision. You split the iliac apophysis, you take down the abductors, you do your standard anterior approach, which you're all, I'm sure, quite familiar with. You do your reduction and then your capsular plication. And most people do the capsular plication very much as described by Salter, but that's not the only way to do it. But that's the most common way that people do. And that's what I do if I'm doing an anterior open reduction. Children wear a 1.5 hip spica for 6 weeks. I have done bilateral cases at the same time, but I find it a little more difficult. And so most people, I think, if you have a bilateral high and you're using an anterior approach, most people separate those by 4 to 6 weeks, but you certainly can do both together. And the involved side, I use the spica all the way down to the foot. So the anterior Smith-Peterson approach has the advantage that it's very familiar to most people, and there's nothing wrong with it. If that's the approach you feel most comfortable with, you should do it. But I don't like it because you disturb the iliac apophysis. You can get a growth arrest. So if you do the anterior approach, never use cautery to split the iliac crest because you will destroy the cartilage. So always use a knife and try and get it in the center so you split the cartilage equally. Also, you're taking down the hip abductors and the rectus. So those are things that are normal muscles and there's nothing wrong with them. So I don't like that for that reason. And so in the 70s, I developed this anteromedial approach because it seems to me that's directly over the obstacles that are keeping you from relocating the hip. And this is ideal for children under 18 months of age. And it's ideal if that's the only thing you're going to do. If you have plans to do an acetabular procedure, well, you're not going to use this approach. So when I'm using this approach, my plan is only to do an open anterior medial approach to the hip. So that's only thing I'm doing. Secondly, the other advantage is you're really not injuring the hip abductors, which are so important. You're not running risk of injuring the iliac crest. The scar is beautifully hidden in the groin. You can do these with basically no blood loss. You can easily do both hips at the same sitting. And some people say they can't see. And as a moment, I'll show you how you can see, I think, a lot better than you can see through an anterior approach. But these are criticisms of this approach. And again, I have no, yes, it's what I use, but you need to do what you feel most comfortable with. So this is a unilateral case. If I were doing bilateral, I would drape off the groin and the rectum, and I would prep both legs free. You can see the adductor longus is quite tight. And here's the incision. Now, this looks quite big, but this incision is only about an inch long or 1.5 inches long. It's very small. It's in the groin crease. You identify the femoral neurovascular bundle and the adductor longus, and the incision goes from just inferior to the neurovascular bundle to the lower border of the adductor longus. Then you find the adductor fascia, which is incised longitudinally in the direction of the adductor longus. These rake retractors are Sen retractors, so you can see how small this actually is. In my younger days, I didn't use loops, but as I've got more senior, I tend to use loops when I do this procedure because it is a small incision. There's the adductor longus, which I isolate, and I do a myotomy, not a tenotomy. I use my bipolar cautery to section the muscle. Now you can see, excuse me, the anterior branch of the obturator nerve sitting on the adductor brevis, and just superiorly, you can see the muscle of the pectineus. So I'm using the anterior branch of the obturator nerve to find the pectineus, and the anterior branch goes under the pectineus. So now you can see the anterior branch of the nerve, you can see the pectineus, and now I'm entering the interval between the pectineus and the neurovascular bundle, so just superior to the pectineus. And you can see I've retracted the pectineus inferiorly. You can see the femoral vein. You can see the anteromedial capsule, and you can also see the medial femoral circumflex vessels crossing the field. Now, distally, I'll take my pointer, hopefully you can see it. In this interval down here, will be the iliopsoas, which you'll see on the next slide. So in that interval, I find the iliopsoas tendon. I take a right angle retractor, which we would call a Kantrowitz or a Krupp. It's a right angled hemostat. I elevate the psoas and then I cut it sharply with a 15 blade. So now I've released the psoas. I've released the adductor longus and I've released the psoas. And now you can move the proximal femur around quite well. So again, here is the femoral neurovascular structure. Here is the medial femoral circumflex vessels, and here is the hip joint capsule. So I take my dissecting scissors and carefully dissect under the neurovascular bundle. I dissect over to the right side here. So I'm totally exposing the capsule. Now I've made a longitudinal incision in the capsule, as you can see in the cartoon on your right at the anteromedial border. And at that point in time, there you can see the ligamentum teres. So I reach in with a little hook, so-called Graham hook, and I catch the ligamentum teres. Now I can follow the ligamentum teres up to its origin on the femoral head. So this is where the ligament inserts on the femoral head. And I take my knife and I cut the ligamentum teres off the femoral head. Now you can see I'm grasping the ligamentum teres. Here's the pectineus down below. Here's the anteromedial capsule. So you can see I've got my dissecting scissors inside the capsule. Here's the ligamentum teres. I've retracted the pectineus inferiorly, and now I cut the anteromedial capsule, which is the primary obstacle to reduction in late diagnosed cases. So I'm taking a sharp knife and I'm cutting the anteromedial capsule, and I also cut the transverse acetabular ligament. Now, excuse me, this is a pituitary rongeur, and all of this is the fibrofatty tissue of the pulvinar. Here's the glistening tissue of the peripheral acetabular cartilage, the so-called knee head. Here's the medial circumflex vessels. Here's the suction. Now, I've cleaned out the acetabulum with the pituitary rongeur, and you can see the this is the anteromedial edge of the capsule. Here's the glistening non-articular medial wall. Here's the peripheral acetabulum, the so-called neolimbus. And now I can directly reduce the head perfectly in the acetabulum. And you can see that it's quite a good view, at least the way that I do it. I do not do a capsular, there's no way you can do a capsular plication, totally impossible. And you're relying on your casting to let the scar tissue close the capsule and tighten it just like you would if you had a successful closed treatment. So I don't believe that capsular plication, if you're successful here, is absolutely necessary. I close the adductor fascia, the subcutaneous tissues in the skin, and then I place the same type of hip spica. So this is a unilateral case. You can see the molding of the cast, and then I document it either with an MRI, and then it's the same post-treatment as a close reduction. 6 weeks with the cast below the knee, 6 weeks with the cast cut above the knee, then a full-time abduction brace for 2 months, and then night and nap time as long as the child will tolerate. And again, I've done this now for 47 years. It has served me quite well, so I'm very happy with this protocol. So let's look at a case which I think is quite interesting and shows the importance of arthrographic documentation. So this is an 8-month-old, a little too old, I would say, for Pavlik harness. It's a completely dislocated hip, significant dysplasia. On your left is a regular AP, and here's an AP in the operating room, and you might think that looks pretty good. Now, the ossific nucleus is smaller, but it was always smaller because of the dislocation. But you might think to yourself, that looks pretty good. But in actuality, it's not good at all. Here's that plain film, and here's the arthrogram. And you can see you've got a huge ligamentum teres here's the medial wall of the acetabulum, and this femoral head is nowhere near the medial wall. It's actually posterior. And here you can see the peripheral acetabular cartilage. So here's the AP arthrogram, there's the abduction arthrogram, and this patient needs an open reduction, which she had, and there's the postoperative CT. So now let's talk about dysplasia a little bit, because this will lead into our discussion of when do you need to do an acetabular and or femoral procedure. I think you can take to the bank that dysplasia after DDH always leads to osteoarthritis. So what we're going to address now is, can I give you some objective criteria of when you should do a pelvic procedure, when you should do femoral shortening, or both? I talked to you about this before, but this was our group of closed treatment. There's 152 cases followed for more than 40 years, only closed reduction, no open treatment. These are bad results: dysplasia, intact Shenton's line, but anatomic dysplasia. This is disrupted Shenton's line and a subluxation. These are bad results. We know these lead to osteoarthritis. If you look at subluxation, you notice as you follow the patients longer, the hips, dysplastic hips go on to subluxation, and this is a classic example. Closed reduction, accessory centers of ossification here at age 17 looks pretty good, Shenton line intact, good teardrop, but it's dysplastic. It's not a perfect acetabulum. Here at age 44 and here at age 53, dysplasia going on to subluxation. Again, dysplasia after DDH always leads to osteoarthritis. And here's another example. This might be a teenager with dysplasia. Post DDH treatment, I did an open reduction on him at 18 months of age. Here you can see at the time I was thinking about doing a pelvic osteotomy. Here's the arthrogram. You can see that this cartilage, which didn't ossify, is not sufficient. And what happens over time, this is 38 years later, the hip subluxates. So just showing why dysplasia can never be accepted. Now, for those of you who also do adolescent hips, I just want to point this out. So if you have a hip that comes into your childhood clinic that looks like this, but no history of DDH, I don't know if the natural history is the same as the patient on your left. Many people who do adolescent hip preservation use the same arguments we use in hip dysplasia, but again, we don't know the number of people in the population who have dysplasia innately. So I don't know about what I'm telling you if it applies to these patients, but I would say everything we're talking about is patients with DDH. Now, I'll also submit to you, if we have a patient like this at 5 years of age and we do a Salter or Pemberton, or this patient is a teenager and we do a PAO, I don't think we know if the results are going to be any better than this patient who just had a closed reduction. We're hopeful that these interventions will prolong the life of the hip, but I would submit to you today, we don't know the answer to that. So when I'm taking a patient to the operating room, I'm always asking myself, do I need to do a secondary procedure? Do I need to do a pelvic osteotomy? And do I need to do femoral shortening? You can practice orthopedics like cooking. You can do a cookbook and say you do the same thing every time for this age or that age, but I try and be a little more nuanced based on the evidence, and I'll give you that evidence today. So we know we can never accept residual dysplasia or subluxation. Are there any objective measures that I can give you that you can hang your head on to help you make these decisions? Because you want to have a hip that looks like this, not this, at the end of treatment. So I'll tell you first, we developed a qualitative measure. That's a subjective assessment of the teardrop development. And then I'll tell you about the quantitative measures using acetabular index. So we studied the teardrop, and we first wanted to know what are the anatomic features in the normal hip that define the teardrop. And this was published in JPO in the 1990s. Then we looked at a large series of patients treated by open and closed treatment, and we looked at teardrop development. And what we found is that if the teardrop is a V, not a perfect tear, here's the normal teardrop on your upper left. If this is what the teardrop looks like after treatment, this hip is always going to do poorly. So I place great stock if I'm only doing a closed reduction or only doing an open reduction and have no pelvic procedure. One thing I'm watching very carefully is teardrop development. So that's a subjective interpretation. Now here's quantitative modeling. These are all patients who had closed or open treatment, but no secondary procedures, and seeing how they developed. So this is the data from this paper, which is in JBJS I think can't remember the year. I'll go back here. It doesn't say, but it's in JBJS. And you can see that in patients either treated with closed or open treatment, no secondary procedures followed to maturity, 85% of children reduced under a year of age, either closed or open, had a normal Severin grade, a normal hip. When you get to 18 months of age, and if you follow Dr. Salter's wisdom, at 18 months of age, you would add a pelvic procedure, you'd add a pelvic osteotomy. But we found that up to 18 months of age, 70% of patients still had a good outcome with just a closed or open treatment. So for me, you'll see in a moment that at 18 months of age, I'm beginning to think about a secondary procedure, but I don't do it routinely because I know that 70% of the patients will probably do okay. Now, when you get to 2 years of age, then it's a roll of the dice. It's a gamble because it's only 50-50. So in my practice, over 2 years of age, because the chances of success are only 50%, I will always do a pelvic osteotomy in conjunction with my reduction. And then at 3 years of age, the results are terrible. 70% of the patients will do poorly. So in these older patients that you face, you need to be aggressive and treat everything. Now, this slide, what it basically shows is that the first 2 years after reduction is the most critical. So if you've done only a closed or only an open reduction, no secondary procedure, if the acetabular index has not normalized by 2 years after treatment, it will never normalize, and you certainly should proceed ahead with pelvic procedures if you don't need to wait any longer. It's never going to get better. So if I summarize that, if I do a closed or open treatment reduction in a child under 18 months of age, I'm probably not going to do anything else, just open treatment. I will follow teardrop development over the first couple of years. If I don't see the teardrop forming normally and it's more V or U-shaped, I'm worried that it won't be normal. And if I don't see normal acetabular index, then I know this child is going to get osteoarthritis and have persistent dysplasia. So I'm going to be aggressively intervening. So to summarize, under 18 months of age, I try a closed reduction. If it's not successful by the criteria I gave you, I do open treatment. I usually do an anteromedial approach, and then I watch for the first 2 or 3 years. And if it hasn't normalized, I'm doing my aggressive treatment. So hence I'm doing my pelvic procedures usually before the children go to school if it's an under 18 month of age patient. This summarizes that again, under a year of age, you're going to have great success with closed treatment alone, and rarely does anyone need open treatment. And certainly, I would argue you don't need any pelvic procedures at all. When you get to 18 months of age, and again, if you follow the widely accepted principles of Salter, you're thinking about doing a pelvic procedure, and there's nothing wrong with that. But I would argue that you're probably doing 70% unnecessary pelvic procedures, and you could afford to wait and do less surgery. So if I have an under 18 month of age patient, I'm going to do attempted closed reduction. As you get closer over a year of age, most of them will require open reduction. I'll look at the acetabular cartilage you can see here, and if it looks really healthy like this one does, I'm again feel pretty comfortable watching and waiting. And then I will just follow the teardrop and acetabular index. And if it's not better in 2 years, I will proceed with my secondary procedure. If it's over 2 years of age, I'm doing open reduction and a pelvic procedure. Now, what about femoral aneversion? We talked in a previous lecture that all these children have excessive aneversion. If you get a successful open reduction by an anterior approach, aneversion will correct over time. But if you feel the reduction, the hip is so high that you're going to do a femoral shortening in conjunction with your open reduction, then you should correct the version at the same time. So at 2 years of age, I'm definitely doing an open reduction. I'm definitely doing a pelvic procedure. And if I think I need the tension on this is also a subjective opinion. If you think the tension on pulling the femur down is very high, then I'm going to do a femoral shortening at the time and correct version. Now, what about the pelvic procedures? Well, the Salter is the most common procedure done around the world, probably. The Sutherland, most people don't do anymore. The triple osteotomy, which I'll just briefly talk about, described originally by Steele and by Dietrich Tonis in Germany, is for older children with more severe dysplasia. And in the US, we rarely need to do it, but you may have more need in India. And then the Pemberton. The Pemberton, you'll see in a moment, is my workhorse. And then if the triradiate cartilage is closed, if you're doing older patients, you're going to be talking about PAO or one of the larger osteotomies, which we won't talk about. These are for patients with closed triradiate cartilage. So I think in DDH, the workhorses around the world are the Salter and the Pemberton. The Degas, which I will mention in a minute, I only use for neuromuscular cases because the Degas, I feel, actually makes the acetabulum smaller. And most children with cerebral palsy, myelomeningocele, neuromuscular dysplasia have a very capacious acetabulum. They have so much instability. The femoral head is moving around a lot. Their acetabulum is very big and you need to make it smaller. So I reserve the Degas for my neuromuscular hips, but some people do use it in DDH. So the Salter, you're probably very familiar with. You're rotating around the symphysis pubis. This is one of my Salter cases. And I'd say this is a very popular osteotomy around the world. It requires the use of internal fixation, and then you need to take the pins out at some point in time. But this, I would say, is probably the most popular osteotomy, and I won't spend any time on it. And this is what it looks like. And that's my follow-up of a very nice Salter. Obviously, it looks wonderful. Now, the triple anomaly osteotomy was popularized by Howard Steele. This is cutting both the ilium, like the Salter. You cut the pubis, much like you would for a PAO, and you also cut the ischium. Steele described this in 1973. And this is, this is a patient that I did a modification. This is a girl I'd done an open reduction. I'd also done a previous pelvic osteotomy, but she still had persistent dysplasia. And I do a modification of the triple, and this was described by Dietrich Tonis in Germany. And it's like an open Salter. It's an open cutting of the symphysis pubis. And then I cut the ischium through that same similar incision I showed you for doing my open reduction through an anteromedial approach. This is just my modification, or Dietrich Tonis's modification. Steele does his osteotomy through an incision in the buttock, and this cut is done here. I just like my cuts closer to the acetabulum, and here's this patient with that osteotomy, and here she is 10 years later. So if I had a child with an open triradiate cartilage, older patient that had very severe dysplasia, that's the type of pelvic osteotomy I would use. But my workhorse for DDH is the Pemberton osteotomy. I learned this from Dr. Sherman Coleman, and I find it very satisfactory. And I'll show you a video here in just a moment of the osteotomy. And I think this is a really good osteotomy to do. It hinges on the posterior limb of the triradiate cartilage. I think it's very artistic. I think it's not easy to learn, but this is what it looks like. And I want to move a little faster. I think I'm going too slow, but I want to show you this video, and I'm going to move it ahead to the technique part here. And it takes about 6 or 7 minutes. So we'll start here, and hopefully, I hope if you don't hear this, let me know.
The patient is a 3-year-old Caucasian female who had a left open reduction for DDH, is positioned supine. A folded bath blanket was placed longitudinally under her body to have the operative field a little bit elevated on the table for a more comfortable position to find the best angle for the osteotomy. The arms were folded across her chest and sandbags were used for stabilization. The approach is through a bikini incision, but caution has to be used in order to avoid complications, such as excessive blood loss, lateral femoral cutaneous nerve injury, and graft extrusion. The lateral femoral cutaneous nerve is clearly visualized, and the interval distal to it is opened very carefully, protecting the nerve. Army-Navy retractors are placed in the interval between the iliotibial band and the sartorius, and a Cobb elevator is used to expose the inferior spine. The hemostat is then used to separate the tissues. The iliac apophysis is then divided sharply from the anterior superior spine and then distally along the ridge between the anterior superior and anterior inferior spine. The iliac apophysis was popped off both medially and laterally. Sponges are useful both for tamponating bleeding, facilitating subperiosteal dissection, and protecting soft tissues during the dissection. At this point, a subperiosteal dissection exposes the sciatic notch medially and laterally, and cobra retractors are placed into position in the notch, as shown here. Cobra retractors are placed into position here, as shown. The cobra retractors in the sciatic notch allow the surgeon a complete view of the pelvis. Now the surgeon has a clear view of the entire ilium and can proceed with the osteotomy after doing an arthrogram to check femoral head coverage. The osteotomy is planned based on the direction in which coverage is needed. If more anterior coverage is desired, the plane of the osteotomy is more transverse, as shown here. If lateral coverage is desired, the plane of the osteotomy is inclined more laterally, as in this view. Once the landmarks of the osteotomy have been determined, the osteotomy can begin. It should begin about 1 centimeter above the antero-inferior iliac spine and proceed posteriorly, keeping a minimum of 1 centimeter to 1.5 centimeters away from the attachment of the joint capsule. At this time, the proposed osteotomy is outlined by scoring the outside and inside of the pelvis following the desired angulation for the cut. It is possible to proceed to the osteotomy. Using small-sized osteotomes, the lateral cuts are outlined on the outer table and going down along the posterior column. As the osteotome proceeds posteriorly and then inferiorly through the outer table toward the triradiate cartilage. The same procedure is done on the inner table going down the posterior column, staying anterior to the sciatic notch. Great care should be exercised to stay in the posterior column and avoid cutting into the sciatic notch. Larger, wider, as well as curved osteotomes are used to extend the osteotomy. When the osteotomy is completed, the acetabular roof can be levered down into the desired position. Spreaders are used to widen the bone periodically in order to open the osteotomy and allow propagation of the fracture. Now the lamina spreader can be used to gradually open the osteotomy. The fluoro can verify that the desired coverage has been achieved. With a lamina spreader in place, we can see that the cuts are excellent, and we are getting excellent bony coverage of the osteotomy over the femoral head. Once the bone graft is appropriately shaped, as shown, we used the cervical spreader to allow enough room to place the bone graft in position. It is recommended to slowly open the osteotomy, giving time for the tissues to relax and to avoid any fracture. Holding the osteotomy open with the spreader, the graft is placed under compression. The graft should be solidly impacted into the osteotomy and be secure without fixation. The X-ray check shows the correct position of the bone graft and good coverage. The wound can now be carefully closed.
So I'll stop with that and just talk about the DEGA for a second. In the US, the DEGA is really, people aren't really sure what the DEGA actually is. And so in the US, at least, most people do a modification described by Scott Mubarak, which is sometimes called the San Diego. And basically you make a notch anteriorly here and here, and the notch here, and then you're cutting around so that you're hinging on the transverse limb of the triradiate cartilage. And again, I think this is a volume reducing osteotomy, so I use that in my neuromuscular patients. That's what a DEGA or San Diego would look like, in my opinion. So these are the osteotomies used. I think the Salter's most commonly used around the world. I stopped doing it around 1980 and started doing the Pemberton. It's again, a lot more artistic. It's a lot more difficult, but I do think it gives me the ability to cover the acetabulum how I want it. I mean, cover the femoral head how I want it. I can get more lateral or more anterior coverage, and I don't have to take pins out. So then we'll quickly up to the femoral shortening issue. So at 3 years of age, I am always doing open reduction, femoral shortening, and correction of version, because after age 2, the version will not correct. So I'm always correcting version. And here in the 3-year-old, I'm doing everything. Just a note about femoral shortening. If you're doing it, let's say in a 2-year-old, or how much do you shorten? Well, the way I do this is I do my lateral approach to the femur first. I fully internally rotate the femur. I put a 1/3 tubular plate in a small patient. I attach the top 2 screws. So I know that this is full internal rotation, the way the screw is oriented. Then I loosen this and flip the plate out of the way. Then I go and do my anterior open reduction, and I use a tenaculum, points that you would use in trauma fixation, and I control the proximal fragment with those points as to grasp the proximal fragment, do my capsular plication, and then whatever the overlap is, once the hip is reduced, then I cut the femur off appropriately. It's not very scientific. It usually amounts to 1 centimeter. If it's an older patient, then I'll use this as my bone graft. But like as you saw in the last video, if I'm not doing a femoral shortening, I'm using a cadaver allograft for my bone graft. So lastly, this is an older patient with a full treatment, open reduction, femoral shortening. Here's the Pemberton, and here's where I place the bone graft, which I took from my femoral shortening. And here's the patient with a follow-up. The last comment I'll make before I start to turn it over for discussion is I do all of my older patients with an anterior approach like this. I don't like to fight the operating table, so I elevate them. And I also like to see the other leg, and I prep and drape both hips free so I can get my spatial orientation. Even in my textbook, we always show the patient bumped up to the side, but I like to have the whole patient exposed so I can kind of get my landmarks. And so this is how I do all my hip surgery. So again, I hope this has been helpful to you. These are obviously my personal opinion, and I'll emphasize again the fact that dysplasia discovered de novo in adolescence. I don't know the natural history because I don't know the N in the population, but the natural history of dysplasia in DDH is crystal clear. These patients all get degenerative joint disease, and the things we're trying to do are trying to hopefully prolong the life of the hip. So again, for approaches, I think the anterior approach, if that's what you feel comfortable with, you should do it. For me, under 18 months of age, I always use the approach that we described back in the 1970s, but you just have to do a good job and accomplish a reduction and make sure you document it. So thank you very much. And with that, I'll stop talking, open the floor for discussion, and let's see. Have I stopped sharing? I hope.
Yeah.
Yes, yeah.
Thank you very much for the excellent talk and the technique. We are open for the discussion. Before anybody asks the question, I will ask you. You said you will do open reduction with anteromedial up to 18 months, but you don't do any acetabular osteotomy till 2 years. So what is your approach with 18 months to 2 years?
Yeah, so that's a really good question. And I would say that I am not a cookbook orthopedic surgeon. But I think when you're starting your practice, you need to have an algorithm to follow. So under 18 months of age, I'm a great believer in Mother Nature, and hopefully there'll be recovery. So between 18 months and 2 years of age, what I do is I go to the operating room, I do my open adductor tenotomy and psoas release, do my arthrogram, and then at that time I make a decision. Do I feel that I'm going to be able to do this just either probably open, and do I think I need an acetabular procedure? Does the arthrogram show that the peripheral acetabulum is so flat? Then I might consider doing the reduction through an anterior approach and just close my adductor incision and go to to a standard anterior approach. So it's a decision made in the operating room, and I prep the parents for both.
Okay. Excellent. Second question. When you have the child with the irreducible hip, very young child with a failed in pelvic harness because it's not reducible. So what is the earliest age you do the close reduction under anesthesia?
Well, so that's more of an anesthesia, your anesthesiologist concerns, but to be honest with you, I mean, you operate on septic hips in newborns, and So for me, as soon as I make the diagnosis of a dislocation or failed Pavlik, then if they've been in a Pavlik and they failed, I let them stay out for a couple of weeks just to get mobility. Then I schedule them for the operating room. So I don't subscribe to waiting for a certain age. You know, a number of years ago, people waited to do open reductions till the ossific nucleus was present. My feeling about that is you're wasting time. The longer the head is out of the acetabulum, the less remodeling potential. So I don't have a lower age where I won't do it. So as soon as I fail, I go to the operating room at a reasonable time thereafter.
Okay. Then that question is there. What is the rationale of splitting the apophysis, iliac apophysis? Can we go without splitting the apophysis?
I think you probably could. If you're doing an anterior approach, you can go below the apophysis and do your periosteal stripping below that area. And I think that's fine. I think just traditionally, most people have done a splitting of the apophysis, but honestly, I think that's a perfectly reasonable way to do it, but you still have to expose the rectus and take the abductors off. So that's the reason under 18 months of age, I don't do that, but you certainly don't have to. If you're only going to do a reduction, you do not have to split the apophysis.
Okay. And one more question, that after the 6 months, the closed reduction take place and reduction is maintained by the K-wire. And it's one of the recent article was also published in Journal of Pediatric Orthopedic. Is it acceptable?
Well, I would say it's acceptable, but it's not. I don't like to do it. I think there's nothing harmful. A single K-wire going through the neck, through the head, even into the acetabulum, as long as it doesn't break off, will not cause a disturbance. My feeling about it always is that, since I've never had to do it, that you just need to do a better reduction. But let me say, you know, that's just my experience, and there's nothing wrong with doing, if that's the only way you feel you can hold it. But I always feel I can do it through a cast and good casting technique, but nothing wrong as long as the pin doesn't break off.
Yeah. Thank you. And one more question you have already answered, but is the capsular raphe is mandatory?
I think when you do an anterior open reduction, because you've done so much dissection, I do think it's absolute, because you're cutting the capsule in a different way. So I do think the capsular plication in the anterior open reduction is what keeps the femoral head located. In the anteromedial approach, it's the cast that keeps the hip located, and the capsule will close itself, scar in. So I don't think it's necessary. Some people even say they keep the ligamentum teres and they sew the ligamentum teres in there. I have never found that necessary.
Okay. Coming to that question, I can add one that when would you do the capsular raphe, when you do the full procedure in older child with more than 3 years, open reduction, femoral shortening, and acetabuloplasty. After the femoral shortening, you do the before.
Yeah, I did a 6-year-old last week,
Okay.
and so I always start with the femur.
Okay.
And I get in that case, I used a blade plate, not a 1/3 tubular plate, but I used a plate that went right up the femoral neck, and I establish my version. I just know, and I get my plate and into the neck, establish version, then I cut my femur, and then I leave the femur, the distal femur alone. Then I do my anterior open reduction, and I control the proximal femur with the points. I don't know if you call them points, but you use them in fracture care a lot. And I grasp the upper end of the femur with my points, and I get it reduced, and then I have someone hold it still while I do the capsular plication. Then I put the distal, I do my femoral shortening, I put my plate on, and then I do my pelvic procedure. So that's the way I do it.
Okay. Then we have got one more question. In Pemberton, where do we stop? been cut, there is there any landmark for our endpoint?
So with the Pemberton, I have those cobra retractors in the sciatic notch, and I manipulate them. I pronate or supinate, have my assistant pronate or supinate, so I can see the posterior column, both laterally and medially. And I use my curved osteotomes to go along the posterior column, but in front of the notch, because you're basically trying to create a controlled fracture. And to be honest, I had one case, which they euphemistically call a Pember-Saul, because it broke into the sciatic notch and it becomes a Salter.
Yeah.
So that happened once, and then you have to treat it like a Salter and pin it. But I try and visually look at the posterior column, both laterally and medially, so that I can make sure that my small curved osteotomes are creating the fracture I want to create.
Okay, excellent.
I didn't get that. Could you try it again?
Have you got any case where the hip has dislocated in hip spica?
Well, I have never had it dislocated in a hip spica ever in hundreds of cases, because again, I'm not bragging, but I'm old enough that my plaster technique is good. And I feel that I can really put on an excellent hip spica cast.
Okay.
And so I've never lost a reduction ever. And I realize that's not everybody. But I spend so much time in plaster technique. And again, it's a function of my age and treating everything by plaster. So I feel I have good plaster techniques, and I don't delegate it to somebody else. I'm not giving it to a technician or a registrar. They're holding the hip while I'm applying the cast.
One more question for the trainee. What are your indication at this area, the actually traditional Salter osteotomy?
For Salter?
Yeah.
So I think prior to my learning the Pemberton, the Salter was always my go-to osteotomy for hip dysplasia. And you should also know that there are a series of Salters actually being done in adolescents, with the triradiate cartilage closed. If the dysplasia is mild, you can do Salters even in teenagers. So there's some good series on adolescents, but so I don't have an upper age limit, but in general, in the modern world, when you have dysplasia in the teenager, they're more often getting something like a PAO or some type of GANS, some type of more aggressive. But Salters can be used even in teenagers, but with mild dysplasia. So Salter, if that's the one you know best, then just keep doing it. The Pemberton is a lot more, I think, difficult. It's more artistic, but I like it better because I feel I can be more creative in what kind of coverage I want to get.
Yeah. We have overshooted. Do we have a few questions? It's okay? Should we go
Yes,
ahead?
of course. I'm yours.
Any tips in the medial approach to prevent injury to circumference vessels?
So I would say early on, I wasn't that careful when I was just learning or making this approach up. And I did injure some, but I didn't get any adverse consequences. But what I do is I never retract on them. And sorry for my hands, but what I'm trying to describe is when I'm in that interval, if I'm pulling on the neurovascular bundle, I don't retract, I don't pull apart. I just pull one side or the other. I don't pull both because it's a very small hole, and I'm always watching them and I work underneath them, but I just try and preserve them. But I will frankly admit that in my earlier days, I sometimes injured them, and but I try my hardest not to injure them, because as most of the listeners will know, I mean, that's arguably the main blood supply to the upper end of the femur. So you do have to be careful. But again, we want to be careful in all of our surgeries. So I just am very watchful and pay attention to detail.
Oh, good. One more question. How much flexion and abduction at hip is safe in the plaster?
So usually the flexion is at least 90 degrees. For the anteromedial approach or closed reduction, it's almost always 90 degrees, but probably not more than 100, 110, because you don't want to get compression of the femoral nerve. And the abduction, I judge intraoperatively when I'm looking at my reduction. I would say 45 degrees would be the most I would probably want to go. But I'm also looking at my arthrogram if it's closed treatment. If it's open, then I'm looking what I do on the open. Once I've got the hip reduced, then I'll adduct and see when it tends to come out. And so just like you would with a Pelvic, I judge my safe zone. But once you do an anteromedial approach and it's very stable. But in general, I think 45 degrees is the most you want to have abduction, no more than 110 of flexion in general.
Okay, then one more practical question for holding the leg and spica. That holding the leg and the hip during the plaster application, or where should we surgeon go? Either holding the leg or primary molding the spica, the gluteal region.
So if I'm doing an anteromedial approach or a closed reduction, I am holding the patient in the position and lifting them on the spica box and holding the position I want. And then I get one assistant to hold the one leg, and then the other assistant, the more senior assistant, I have hold the DDH side, and I tell them not to move. So I'm applying the cast, and I'm making sure the hip is always held just where I want it. I don't know if that's helpful, but so I'm holding it until I'm just ready to apply the soft roll, the padding, and the cast. Then the assistant holds and I do the casting.
Okay. Yeah, would you just explain the position of child during the surgery?
So for an anteromedial approach, they're just supine on the operating table. And if it's a unilateral case, I use clear plastic tape and benzoin, and I close the vaginal area or the scrotum and the penis and go all the way across the rectum. I just seal it off with 1-inch or 2-inch plastic tape and benzoin. If it's bilateral, I do that and prep both legs totally free. If it's a anterior open reduction, then I have the patient elevated off the table on a bath blanket, sandbags to secure the chest, and a pillow, like I showed in the last slide.
Okay. Yeah, then one more question is there. When will you consider about femur varus osteotomy? Anytime?
Well, the answer to that in DDH is never, because valgus is not a component of DDH. When you're talking about hips in neuromuscular diseases where valgus is a component because of the muscle imbalance, so if I'm doing cerebral palsy, it's always varus derotation. In DDH, the only abnormality on the femoral side is anteversion, so I'm never doing varus. I'm just correcting version.
Okay. Yeah, that's one more question. Would you ever encounter the asphericity of the femoral head in an older child?
All the time.
And what will you do?
There's nothing you can do about it, but even in younger children, if that's a high dislocation, the femoral head is often not round, but flat.
Yes.
So you're again, reestablishing the relationship between the femoral head and acetabulum and hoping for good remodeling. So that's all you can do. So they often, particularly the older the patient, they're not congruent. And you're hoping the child has enough growth and remodeling potential that they will remodel over time and be fine.
Okay, that's the question which I ask you first, remodeling potentials. What is your opinion and approach for the older patient when you'll not do the open reduction or not touch it?
Sure. So I think the difference is unilateral versus bilateral. And, bilateral high dislocations, they have a very abnormal gait. It's a waddling gait and hyperlordosis, but they generally do well. They have back pain later in life, but the hips often don't hurt if it's a very high dislocation. So in my country, I guess in my practice, over age 5, in bilateral cases, I try and convince the family to just leave it alone if they're willing to do that, because I think the risk of problems is greater. In unilateral cases, I will almost always do the reduction because the gait is so unsightly and they're going to need a total hip. If the other hip is normal, so even an 11-year-old, I might do an open reduction, femoral shortening, acetabular procedure just to make them a better candidate for a hip replacement later in life and to have maybe a better childhood. So these are really difficult questions. And I think the family and the child has to buy in. I think most children with unilateral dislocations are extremely unhappy with the way they look and the way they're perceived by their peer group and by society. And for girls, it's probably hard to get a husband, I would say. Yeah. So I think unilaterals, I always reduce in general. And then bilaterals after age 5, I try and leave alone.
Okay, coming back to the older patient in unilateral, would you ever consider with the open reduction with a triple osteotomy?
I think in the older patient, if you're going to do an open reduction, femoral shortening, and reduce the hip, you most always will have to do a much bigger osteotomy, and the triple, would probably be the type you would do. I mean, these would not be candidates ever for a GONS or PAO. These are only candidates either for some type of triple or even a shelf, just something to keep the hip in and located so that later on they can have a more successful total hip replacement.
Yeah, and continue to that question, how would you manage the limb length discrepancy? Because many times they will have a huge shortening, maybe 4 centimeter, 5 centimeter proximal migration. How do you address the limb length discrepancy?
Yeah, so I'm going to do everything possible to get the patient at a younger age where there might be some room for epiphysiodesis on the other side, which doesn't harm the hip, but gets them closer in length for a good total hip. But once you get to like a girl over 14, there's no chance. I wouldn't be doing femoral shortening on the other side. I don't want to take a good leg and make it a bad leg. So I would do the best I can, or encourage the child not to do anything and maybe find a very, very, very skilled surgeon who could do a total hip in a bad unilateral dislocate. And that takes a very skilled surgeon.
In other sense, would you consider about the significant amount of shortening to have a limb lengthening on same side for increasing the pressure on DDH side, operated side?
I think that's a difficult question because theoretically limb lengthening should only be done in the face of normal joints above and below.
Yeah.
So I think, yes, it can be done, but I think it's fraught with potentially bad outcomes. So yes, you can do anything. You have the technology to do anything you want to do, but I think it's ill-advised when you don't have a normal joint above or below. But sometimes you have to do it because the situation without doing it is so poor. Like in my country, we've seen some bad septic arthritis where they have a really bad hip, but the shortening is so great that it makes it non-functional. So yeah, there's always circumstances, and nothing is ever black and white in these type of situations.
You have already addressed one more point, but it's again one more time question. How would you decide how much derotation and amount of derotation for antiversion?
Sure. So I think we're lucky in children because they have so much remodeling potential. Our adult colleagues who are doing complex osteotomies are very precise in planning. I think when you have a young child, 3, 4 years of age, 5 years of age, I just basically, I put my plate on the proximal in full internal rotation, and then I judge the knee the distal segment, and I put the knee in approximately 15 degrees of internal rotation, and that's where I secure my plate. I think our adult colleagues in mature patients are much more precise. We are lucky because we have growth and remodeling. We can get it close, and the child will remodel. So that's how I judge it, very crudely.
Okay. And the one more question for our trainee. What is your opinion for the self and Chiari osteotomy in current era, where there is a PAO and triple is more popular and more advanced for the hyaline cartilage? What is your
So the
opinion?
PAO versus.
Now, opinion for Chiari and self, salvage self.
Oh, okay. Yeah, Chiari. Yeah. So I have a lot of experience with Chiari. I did a lot of Chiaris in older patients in my younger days, and I would say it's a very good operation. And there are good 25 to 30-year follow-ups of Chiari, but it's hard to sell a Chiari osteotomy in 2023. The patients limp for a very long time. But I can show patients examples of really good results, and it's a much easier osteotomy than a PAO. But I think in 2023, in an educated population, you would have a difficult time convincing someone to have a Chiari. Now, a shelf is where you have no other choice. No other osteotomy will do the trick. And a shelf is a very good operation. I mean, easy, it's predictable. And as long as the shelf bears weight, it will hypertrophy and last a very long time, and also make a hip replacement if the patient is a candidate much better. So the shelf for me is when I can't accomplish anything else. And sometimes I will even add a shelf to another osteotomy. So let's say I've done a Salter or Pemberton and I'm still unhappy, or PAO, I might put a little bit of a shelf there to add on to it. But I think in general, shelves are salvage procedures. Chiaris are considered salvage, but my long-term Chiaris are wonderful, except for the limping. And nobody does Chiaris, I don't think, anymore today, at least in the US. I think you look like a dinosaur, but I do think it's a very good operation.
Yeah, I agree with you. And there are some times when there is Chiari will have role. But only I have one more question related to Chiari. Because of the limb, would you consider about the trochanter? Because the abductor lurch, because its mood is proximal, so that the abductor length, it will become lax. So would you do something to avoid the limp in case of Chiari?
I have not done that, but it is a very reasonable solution to consider. But I haven't done it, so I can't answer intelligently.
Okay, thank you, because that is the very important question because of the limb. It's the forces of the hip is getting less, and they are lasting longer, which we have seen also. But I want to know from the 47 years experience that you will have the very long-term follow-up of Chiari patients. It is a wonderful operation.
Yeah, and I think that there's good results in England and everywhere. There are good follow-ups of Chiaris. So I still think it was a wonderful operation, but when I talk about it in a lecture, it's like, this is ancient.
Yes.
So, but yeah, I think it's a good operation.
Yes. One more question. Have you ever encountered in any patients where the articular cartilage without any intervention is not normal in case of DDH?
Well, we don't really biopsy the cartilage, so it's hard to say.
No, it will be like a cerebral palsy, like it gets eroded.
Oh.
Sometimes with medial side, particularly on the pressing on the pelvis, where the femoral press on the pelvis.
Yeah, when you're talking about cerebral palsy, very few of those hips, they're all eroded. They have oftentimes terrible defects in the femoral head. The acetabulum is not normal. So these are terrible hips. So yes, especially the femoral heads in cerebral palsy are terrible. And, then it's a debate whether you do a reduction or you do a resection.
Yes.
For pain. So difficult situation.
And we'll have one more question that have you ever, what is your approach, the difference between the MCC or AMC hip and idiopathic hip in young age, 1.5 year?
I'm sorry, I didn't understand.
Arthrogryposis, multiplex congenital.
Oh, arthrogryposis. That's very difficult. An arthrogrypotic hip does not fall in the same category as a routine DDH.
Okay.
But when I have a dislocation in an arthrogrypotic, even in a newborn, if it's a very high dislocation and it's bilateral, I prefer to leave them out. In a bilateral high dislocation in a newborn with arthrogryposis, I will encourage the family to leave them alone. If it's unilateral, then I do try to reduce them, but they are extremely difficult to do. And in some young patients, I have done an anteromedial approach, but it's often quite difficult because the hip is so high and the tissues are so bad. So those often will require an anterior approach. But I have done them in anteromedial approach. But I think the results in arthrogryposis are very poor in general. And again, if it's bilateral, I encourage them to be left out.
Thank you very much for the point in arthrogryposis, because many of the time, many young surgeons are very aggressive for the bilateral hip on that. So last question, what are the possible direction of DDH surgery that you anticipate in future?
Oh, what's the future? Well, to
What
me,
about the arthroscopic surgery? Like, say, do you see that will it come and like will replace the open surgery?
Well, one comment is I think the key to all of this is early diagnosis. To have our primary care physicians make the diagnosis in the nursery and get a Pavlik harness on so we don't have to do these things. I see and I know people who've done arthroscopic procedures. I am a bit skeptical. I think a well done, you have an incision no matter what, whether it's with an arthroscope or a small surgical incision. So I don't see the benefit of it, even though people do it. I mean, people do a scope for everything. So I don't see that as the future. I think the future is developing some biologic answer to acetabular dysplasia, that maybe you can inject something or do something that'll make the cartilage turn to bone or restore normal growth. To me, again, the answer has always been early detection, because Pavlik harness or some device like that has like a 95% chance of a normal hip. So, but it's pretty hard to educate primary care physicians. Even in the US, it's almost impossible.
Okay, thank you very much for the wonderful discussion. Over to you, Dhiren bhai. I will say thanks.
Yeah, thank you, Professor Weinstein, for a wonderful explanation about the surgical technique. I see this lecture from 2 points of view. The first, it will definitely increase the confidence of surgeon. And the second, it will definitely help us to reduce the complication rate of this surgery. So I'm sure that your vast experience of 47 years is going to help our trainees and our fellows to improve upon their surgical skill and will help them to get better results. So with that, on behalf of all trainees and all fellows, I thank you once again for sharing your experience with us. Thank you and bye-bye.
Thank you. Thanks for coming.
Yeah, thank you.